both the number of items, but also the time spent. And we divide it into three categories: a strategy, accountability, and culture. I think I would be correct in saying, although both Matthew or Rebecca may wish to correct me, but what we tend to find is when you look at the year as a whole, it evens out very well. And we actually do spend roughly a third on strategy, culture, and accountability. What tends to happen, however, is at certain times of the year, certain things take priority and take more time. Clearly, at the time that GGI were in, there was a lot of work going on about the 23-24 plan. There were lots of the other, as others have said, we were dealing with a lot of emerging operational challenges, and I think that probably is what they saw. But I think we actually have a fair level of assurance that, in fact, overall, we are addressing all those areas pretty evenly. Again, I don't know if Rebecca or Matthew want to comment on that.
Just to confirm that it's part of our well-led evidence, in effect, is that we're able to triangulate that that the board discussions have been spread, and very much that the board assurance framework is driving the board's agendas, and that we can qualify that back, that we're not having discussions on purely on finance or other areas at the expense of quality or workforce or well-being. And the quarterly board review that we undertake really gives us good evidence to be able to demonstrate that we're doing that, and to give the board ability to recast its agenda should we need to make any changes to that. Thank you.
Absolutely. Thank you, Rebecca. Okay, if there are no other questions or comments, we are asked to confirm an assurance level of 4. We happy with that? Thank you very much. I'll just pause there for a second. Is there any update on the video stream? Do not have a fixed ETA. Okay, let's carry on for now, and we'll see. Hopefully, there will be a resolution before too long. Quality account, Sue.
Thank you, Chair. So these quality accounts are being presented to Trust Board today for approval, and I'll take the paper as read, Chair. Lots of work has gone into producing these quality accounts, and I'd like to extend my thanks especially to the Healthcare Standard team, who've done an awful lot of the collating and producing of these accounts, and also to all those involved in providing all the information and data in there, in quite tight timescales at some point. So thank you to everybody involved. The draft quality account has been socialised at both TME, so Trust Management Executive, and QGC, Quality Governance Committee, and that was during May, and comments and amendments have been included in the draft account following those two groups. The draft's also been sent to our stakeholders for their review and comments, and their feedback is also included in the accounts, and the actual direct feedback is on page 67 at the end of the report. To address one question which came up, and a theme was around having an easy read version of the quality accounts, because it was noted at QGC that actually the accounts were quite long. I have had a conversation with Sarah, our new CNO, and regarding this, and we'll be working in conjunction with our patient and public forum members in regards to this point, and as part of review and development of a patient voice and engagement strategy for the Trust. So as I said, the paper's here today for approval. It needs submitting to the Department of Health by the 30th of June. So I'll pause there, Chair, and happy to take any questions. Thank you.
Thank you, Sue. Any questions or comments on the quality account? It is a long read, but there is some good stuff in there. Simon.
Thanks very much. And yes, it was a very interesting and positive read in many sections. And I was pleased to see that our clinical research team won the West Midlands Award. And perhaps it's also appropriate just a minute here, our gratitude again to the Worcester Mellor for their support with the memorials that was also mentioned in the report. Question I have, I think you started to touch on it, because obviously we've got some stakeholder feedback, certainly from Healthwatch and from the PPF. I note the point about the easy read version, but there were other points in there. So I don't know if you could just give a quick summary of how we might be responding to some of those. So.
A lot of the, thank you, Simon. A lot of the comments we received were around clarification. So a lot of it around the language that was used, clarification around certain data that was in there. So we just put more explanation in the paper, especially from the PPF and Health Watch, those comments came from. So that was very much what we included.
Thank you, Sue. Richard.
Yes, I think it's maybe also building on Simon's question. So I think it's a great report. It's great that we do an easy to read summary, because I think there's a lot of valuable information that should be accessible to the public. So that's very positive. We also made some good progress in a number of areas, so the content of the report. But what I missed, as well as Health Watch, is really more quantified, smart objectives around some of the objectives that we've put in for this year. So there's maybe not something in the report per se, but as a follow-up, I'd really like to see those specific smart objectives, because I think we need those. And specifically, I'd be really interested in the path to platinum accreditation. I know, we kind of paused it more or less to the operational pressures. We've got 13 wards that have achieved gold so far, but this is really about behaviors. There's quite a lot more to do. And I'd be interested to understand what's our plan to really get all of our wards gold accredited.
Thank you, Richard. So we, yes, past to platinum, we're in a process of reviewing that. You're right. It was paused for a certain point during because of all the COVID work. We've actually gone into a phase 2 launch, which we're going to discuss with Sarah. We've got a date to discuss that, I think, Sarah, haven't we, on the 27th of June, and to find a way forward with that. We've actually got a couple of pilot wards for the phase 2 already, one on the Alex site and one on the Worcester site, to actually relaunch that, looking at, in conjunction with Sarah, a new dashboard for the metrics we'll be using for that. All the wards are very keen to get back on board with that, so it's a really positive thing. But we're hoping, with Sarah's approval, that we'll have our first accreditation panel to sit in September. So we really are going to be back on track with this.
Thank you, Sue. Christine.
It was just on the question about the measures, really. So what we've been working on, Richard, is ensuring that the quality metrics within our IPR will align to the quality priorities within our quality account priorities for next year, so that you will be able to see our measurable progress in those areas.
Thank you, Christine. Sarah, you wanted to come in.
I was going to say exactly the same thing as Christine. Anita.
Okay, that's fine. Thank you. I had just one question, or maybe a comment. The one thing that I think I would suggest or wonder whether it would be worth considering including in there is actually the continuing rollout of #CallMe in terms of the patient experience part. I know I've seen some data recently that says there are some parts of our organisation that are now 100% have fully adopted it. Others are well over 90–95%. That's actually, yes, there's some work more to do in some areas, but I do think that is an important aspect of our commitment to patient experience, inclusion, and so on. So I wonder whether there would be, you could find a space to perhaps put some of that data in there.
Yeah, we will do, Anita. Thank you.
Lovely. Okay. This paper is for approval at level 5 assurance. Can I have board's agreement to approving that? Thank you very much. Okay. Right, I've been informed that the live stream on YouTube has now been restored. My apologies to our audience on YouTube, who we got to an important part of the agenda, and I gather that the stream went down. So with everyone's agreement, I would like to now go back up the agenda to the paper moving forward on foundation group membership. We had, I believe, I'm told that Matthew had given an introduction and Joe had started speaking when the stream went down. What I would suggest, given that it will all be minuted in the end anyway, shall we perhaps pick up at Joe, and whether Joe we could start from there, and then we'll go forward into the discussion that we were planning to have. So just to anyone on YouTube, don't worry, you didn't miss anything. As soon as we found out what had happened, we paused that paper and went on with other parts of the agenda. So Jo, can I ask you to pick back and maybe start at the beginning of what you were saying? Thank you.
Yes, thank you, Chair. It's a good test for my voice today, isn't it? So apologies if I sound hoarse. So just to remind colleagues, so the paper that's laid out before you seeks to address and bring together two aspects of work, namely, firstly, the succession planning for both the Chair and Chief Executive, and secondly, to build on a review of provider collaboratives, which was part of a paper that went to board in April of this year. And primarily it's to answer the question, how do we achieve a stable transition to allow us to continue to put patients first and deliver our strategy both in the short and the longer term? So I think, as Matthew was outlining, the Trust has experienced quite a lot of stability over the last 5 years, and it's allowed us to put in place our strategic pyramid and our strategy of putting patients first, supported by the forward improvement work as part of our organisational culture journey. And I think as a board, we would assess that actually we've made some very good progress in terms of some of the improvements that are under section 1.4, talking about some of the getting it right first time areas of service development to improve services for our patients. There's a lot of investment we've been able to undertake, particularly in terms of developing our urgent and emergency centre, which will open this year. And again, from a elective recovery perspective, focusing our elective work on the Alex site with the investment in theatres is work that's currently underway. Not forgetting as well the digital strategy and the delivery of our electronic patient record system is a really key part of our work. What's really pleasing across those 5 years is we've also seen our staff engagement in staff surveys improve significantly, and indeed the investment in our wellbeing programmes has recently been recognised. Having said all that, as Matthew alluded to, we've also had some considerable challenges operationally, and I think coming out of COVID, it's recognised that actually the need for mutual aid and collaboration has increased. So as we review the role of provider collaborations, and as has been reported elsewhere in the board, the Good Governance Institute, as part of the Well-Led Review, shared with us, there's been an acceleration of interest in collaborations, particularly around some of the foundation group and the group models. And indeed, the foundation group has been identified as one of 9 innovator sites to pilot and see how that can be developed going forward. And just to note as well, we are an associate member of the foundation group and have been for the last 18 months. So the approach we've taken as a board is to undertake a strategic assessment to review those provider collaborative arrangements, and with the fundamental understanding we need to move at pace to both stabilise our leadership and deliver our vision and objectives. The paper identifies principles that we've undertaken as we've taken that approach. I just wanted to draw out 3 or 4 key ones to the board. First of all, and we've been rehearsing this today at the board meeting, that key and core are our patients and the residents of Worcester and the surrounding counties. So putting patients first is very much at the heart. Second is just to remind ourselves that we've always and continue to be clinically led and managerially supported. Third, again, just to acknowledge that we are an extra large acute trust, and with that, our services and our service portfolio both looks to develop into the tertiary areas and working with partners in those areas, and our ambition in terms of development into the future. And I think on that point, our clinical services strategy reads to the fact that we very much have what we call a pluralistic approach to our tertiary services, which means that actually we go where the patient need is and where the services can be provided. And those relationships are ones that, as a principle, we would want to retain. So as we reviewed all of this work, I think as a board, we collectively identified conditions for success. If this is going to work, these are the sort of things we'd want to look back and say, this is the improvement we've seen. And as well as being able to acknowledge and recognise some of those improvements and celebrate some of the work that we make as a trust, it also recognises some of our strategic ambition, one of which is to develop a roadmap to develop our university hospital status in line with the work that we're doing with the teaching medical school at the University of Worcester. And second of those, and building on the experience that Swift provides us, there's a lot of place provider-led work that goes on in the other member trusts, where they have what's called a vertically integrated model. So they really have a smoother pathway in terms of being able to deliver services for patients under what's called the Canterbury model. And again, that's something that we'd be very interested in building on as we work to improve our flow and experience for patients within Worcestershire. There are other conditions for success identified in the paper, and as part of the proposition, we have tested and gained support from our stakeholder colleagues at the NHSE region and within the ICB, and Appendix 1 identifies written support to help us achieve some of those conditions for success. So the remaining paper, Chair, outlines how we propose to take this forward, noting that we will remain a separate autonomous organisation with its own board, accountable for our own performance and to our local stakeholders. And in conclusion, I think it's fair to say you could say this is at a simple level just a change of leadership, whilst that's really important in terms of the chair and chief executive. But I think our preference is to think of this as an opportunity to provide a catalyst to accelerate delivery of our strategic vision for the trust, for our patients and for our staff. And I think some of that is outlined in the benefit section of the paper in 4.1. We recognise there are risks. We would want to obviously make sure that we continue our engagement, particularly with our staff and with our stakeholders, and have a plan to take us through transition. Those risks are outlined under section 6. And I think I'd propose, Chair, that we pause there, allow the board opportunity to ask any questions, and maybe we can explore those under that section. Thank you.
Thank you very much, Jo. Right, let's open it up for questions from the board, please. You've all gone very quiet on me suddenly. Matt.
Yeah, so just a quick question, just in terms of the foundation group, and maybe this is one that Christine could pick up. It's just about the conversations that have been had, our clinical conversations with our clinicians and the dialogue with them.
Thank you.
Thank you, Matt. Yes, of course, we recognise that the success of any changed leadership model within an organisation is dependent upon taking the workforce with us, and that particularly the consultant body are highly influential and important in that. So in the preparation to making the decision to move in this direction, I've been taking some face-to-face engagement with particularly our divisional directors, clinical directors, lead clinicians, the chair of the medical staff committee, the deputy chair of the LNC, and we've also had very good attendance at our open staff engagement sessions by consultants. What I would say, the feedback from them is that there are a few things that come through loud and clear. The first is wanting to ensure that the model that we're moving into it reaps benefits in terms of our teaching, training, education and academic offer. That's seen as very important in terms of retention of staff and recruitment of consultants in the future. The second thing that comes through is some anxiety about fragile services across the group, and whether, for example, our consultants will be asked to go and work in other trusts within the group to support their fragile services. In some cases, the flip side of that is that some of our consultants are keen to support and help the fragile services within the group, and can see the benefits of sharing our own expertise in those areas where we're clinically very strong. So there's two sides to that coin. And the final thing that comes through really strongly is a desire to retain our culture as an organisation. So recognising the under Matthew's leadership and in having a stable executive team, we have an open, transparent learning culture, and wanting to make sure that any changes retain that culture.
Thank you, Matt and Christine. Simon.
Thanks, Anita. And Christine's actually touched on one of the issues I was going to raise about the potential benefits for recruitment and retention of staff through this new arrangement. And I think she's hit the nail on the head there. Just a bit of information in that case for colleagues. I've had conversations with my opposite numbers as deputy chair at Swift and also Wye Valley. George Elliott, we're due to have a conversation, but unfortunately Julie got stuck in a traffic jam, so I'm speaking to her tomorrow. The reason for me speaking to them was to actually test out this point of, are you still a sovereign board? And the answer that came back from both Simon Page at Swift and from Andrew Cottam at Wye Valley is definitely yes. They still operate as a sovereign board, essentially just with a new chair and a new chief executive. They found, particularly for Wye Valley, where Swift had actually started this movement, that any initial skepticism that might have been held around the board table soon disappeared when people realised there were advantages to this. But the key point being that they did remain a sovereign board, and they still are, and they feel the benefits from this new collaborative way of working as full members of the foundation group has been to everybody's advantage.
Thank you, Simon. That's very helpful. Richard.
So both Simon and Christine have answered some of my question. When I'm really in support of this proposal, we've spent quite some time as a board to discuss it, and we also put quite some time in formulating those conditions for success. And it's great to see the support from Simon Trickett on those conditions for success. But I'm asking us as a board how we manage and report progress on those going forward, because I think that's going to be critical.
Thank you, Richard. Who'd like to respond on that? Jo?
Yeah, thank you, Richard. I mean, obviously, the approval of this is just the start, isn't it? And I think one of the things that we have rehearsed is, I think I've described it as the transition, but we need to be able to pull those conditions for success into a form of an action plan. So actually we can make sure that we can track through and have those relevant discussions that we need to have. And I'm sure Glenn and Russell would also like to have some of those conversations with colleagues in the ICBN region as well. So that will follow.
Thank you, Jo. Colin.
I think it's great to see this trust aligning itself with a development in the NHS, which is seen as innovative and leading edge with lots of potential benefits. But I think it's important we don't do it because it's fashionable, but we do it because there are real potential benefits. And I thought the section in this report, which highlighted the benefits, was really well written. And well, it's very exciting actually to read some of the things that could potentially come out of this new structure. But I did wonder, and I know Christine has touched on this already, but what the view is on the impact of recruitment might be if we are seen as a more attractive recruiter as on the back of this, particularly in the areas that we've currently found very hard to fill.
Thank you, Colin. Christine, can you respond on that?
I can, to an extent. I think the truth is, Colin, that we don't really know. And recruitment across the whole of the NHS is difficult. And most of the areas that we struggle to recruit, other organisations are also struggling to recruit in. However, what I would say is that some of the other trusts within the group have got very strong clinical models in some areas where we don't. For example, the frailty model in South Warwickshire, which has an excellent reputation. It's regarded as a really good, strong, innovative model. We struggle to recruit in geriatrics. And if we can learn from that frailty model and perhaps apply some of the principles in our own organisation and for our own population, it might help us to recruit in that area.
Thank you, Christine. And certainly I recall having visited the frailty model at Warwick, and it's very, very impressive, and certainly it'd be great if we could build on some of that. Tony.
Thanks, Chair. What I'd be particularly interested in is our feelings in response to the comments submitted by Healthwatch, because I think they're very pertinent to the discussion we're having, around complexity and scale in our case. Community beds and the question of our performance, which Richard's also touched on. I'd just be interested in a view coming back from the executive on those 3 points. Thanks.
Yes. So Tony, if you'll what I'd like to do is if we can get through some questions here, and then what I'm going to do is ask Richard Haynes, who's been collecting together all the questions that we've had from various groups, and I think we're going to sort of try and tackle those sort of thematically, as it were. So if you could just hold that thought for just a few minutes, hopefully we'll get to that. Sue, over to you.
Thank you, Chair. I was my residual concern is actually it does relate to our scale and getting too big, but I'm largely come to terms with that. I was extremely anxious about this when it was first mooted, and I think we've been through a process of examination, reflection, and good consideration in before actually bringing this fully to the public board for consideration, which I think has been very measured and thoughtful, and therefore I in principle support this as well, with the caveats that some of my colleagues have just want more clarity on.
Thank you, Sue. Matthew.
Yeah, thanks, Sharon. My comment, I think, reflects back to this comment at least, reflects back to the question around recruitment and retention and some of the concerns that certainly some of our clinicians have raised directly with me. And board colleagues will remember back in early 2020, we, as a board, went through a process of considering and reviewing our strategic partnerships and our partnerships with our tertiary centres, particularly at UHCW, so University Hospitals Coventry and Warwickshire, and also with University Hospitals Birmingham. And because a number of our services are inevitably linked through tertiary pathway relationships there. And we discussed at that time, as colleagues will remember, the importance of those relationships for patients, but also for the potential development of joint appointments and attracting colleagues into the patch who perhaps could do some time at the tertiary centres in Coventry, some time at the tertiary centres in Birmingham. And then, of course, we all remember what happened in February-March 2020, the COVID pandemic came along and disrupted the progress that we're starting to make. So one of the things I'd also remind the board to consider is not just the benefits of being part of the group for recruitment and retention, but also to continue in, after my departure, the conversations with our tertiary partners about whether there's the opportunity to continue to maintain those and build on those strong relationships, because I know colleagues at Birmingham and Coventry are keen to see that happening, irrespective of us joining the group or not. Thank you.
Helpful comment. Thank you, Matthew. Julie.
Health by its nature is a collaborative venture, and clinicians are by nature collaborative. The beauty of this model is, as Simon said, we retain sovereignty. We will make sure that this is in the best interests of our patients, but there are only benefits from greater collaboration, and nothing stops us collaborating much more widely, as Matthew's already said. So I think there are benefits. The thing that's concerned me most recently, it's come up already, is our frailty model. The fact we've failed to recruit to that, and there are brilliant models elsewhere in the collaborative approach that we see. So I am in support of this. It gives us, I think, the best of both worlds, and I think we would be this is a good way to look forward at some of the issues we're currently facing.
Thank you, Julie. That's helpful. Right, I don't see any more hands raised. I wonder, Richard, if I could come to you. Richard, just for board colleagues, has attended, I think, all the staff drop-in sessions. He's also pulled and had a sight of comments that have been submitted by Healthwatch and also by the Patient Public Forum. So I wonder, Richard, if you could kind of summarise for us that sort of some of the issues that have been raised, and then we can perhaps make sure that we address any concerns or questions that have come out of that. Thank you.
Thanks, Anita. I'll make a start, and I'm sure that colleagues who've been involved will join in. Just as an aside, before I get stuck into that, though, thank you to Vicky's team for getting the live stream restored so quickly. If my voice is slightly shakier than it was earlier, then it's because I'm still recovering from that particular challenge. But colleagues will be aware that we discussed at our trust management executive, so with senior clinicians and senior members of the exec team and others, this paper coming to board, and that was how it comes to be here. Following that discussion at TME, we carried out a series of coordinated staff briefings, working with the comms leads across the rest of the foundation group, and that was followed in fairly short order by some wider stakeholder engagements. We then came back to another round of internal engagement this week with 3 open drop-in sessions for staff, Monday lunchtime, Tuesday morning, and late yesterday afternoon. All of those were very well attended, and we saw some very lively discussions. We also welcomed 2 members of our Patient and Public Forum to yesterday afternoon's one. In addition to those 3 sessions, I was able to take advantage of the opportunity to speak about the proposals at a scheduled meeting of our forward advocates on Tuesday. I think there is a high level of interest. I think reassuringly for me, the themes that came across most clearly were those that were already featured in the board paper and which have been outlined so eloquently by board colleagues in the discussion over the past few minutes. So some of the questions that we were asked, we were able to answer definitively around the sovereign nature of the board, around the trust remaining an organisation in its own right, around it remaining the employing organisation of colleagues who attended those meetings. Others, as has been reflected by the discussions at board so far, we were able to go so far, but to say some of these things will pan out as we go through the move into the new arrangement. So what did our people tell us? Well, we heard, and Chair, you were at a session where one of these issues was raised, so you will know that we heard some very powerful testimony from colleagues about the importance of keeping our focus on building a compassionate culture, on being inclusive, on celebrating diversity, on rolling out the behavioural charter, on remaining focused on our commitment to our forward behaviours, on actively supporting our staff engagement networks. And you can see that I'm flying the pride flag on my team's backdrop today to support the work of our LGBTQ+ network during Pride Month. And some very, very heartfelt first-hand testimony from people who really were feeling the benefit of all of that work. I think a recognition of the advantages of stable board leadership to help our teams build on the significant progress that they've made over the past few years, not just on culture, but on also the improvements in safety and quality and patient experience, and all the investment in new facilities and new services that we have seen. Related to that, and this is unsurprising, but I think it was one where we weren't in a position to make any promises, a lot of interest in what this new arrangement might mean in securing even more capital funding for more developments going forward, and also where it put us in lobbying for those causes that are not directly the trust but are dear to our heart. For instance, our ongoing discussions around securing funded places for the 3 counties medical school. We've talked about other collaboratives. Julie mentioned it earlier, and I think very keen that this arrangement supported our continuing collaboration across networks in the other provider collaboratives that we're already part of at place and at system level. And again, linked into that collaboration, a recognition that some of our services face significant challenges, operational pressures, capacity, staffing challenges. A number of services elsewhere in the group face similar challenges, and an absolute understanding of and support for the principles of mutual aid and that desire to work together, but also understandably, I think, a desire for clarity about what does this mean for my service? What does this mean for where I'm going to be based? What will the impact be on my team? And again, an interest in exploring what these new leadership arrangements might do in terms of helping our efforts to deal with what Matthew described earlier as the wicked issues, so the pressures on the front door, and also recognition that there is some learning from elsewhere in the group around the frailty pathway that you've touched on, and that knowledge of working better across systems. So a lot of learning there. It would be fair to say the scale issue came up from staff, from our PPF members, and I know it's one of the issues that Healthwatch have raised, because by any calculation, adding us to the foundation group expands its size significantly. I think, depending on what metric you use, it's somewhere between 70 and 100%, and around visibility of board leadership. And also linked to that, very much a lot of interest in the appointment of the managing director, which clearly is a key role for our senior leadership team. What kind of person we were looking for, a very high level of interest in the process for appointing that person, a very clearly articulated desire to make sure that our MD is a good fit for our organisation. So I think overall, and thank you to Christine and Tina and Rebecca and Joe, who all supported those events, as you and Simon did the Tuesday one, Chair. So thank you for that. And there, you know, all of you are welcome to chip in. But I think I would describe the overall mood as interested and engaged as we would expect our people to be, cautiously optimistic, but a strong desire for more detail at an individual and service level, and a lot of people expressing a desire to meet with our new chair and CEO at the appropriate stage of the appointment process, and a very strong desire to be kept up to date with the appointment of the MD. That's kind of it for my reflections, Anita. But as I say, colleagues who are at those sessions will I'm sure fill in any gaps that I've left.
Thank you, Richard. I wonder if we could, just going back to Tony's comment earlier, certainly Healthwatch, Joe very kindly sent us a letter with some questions in advance, and I wonder whether we could just make sure that we've addressed one. So I think the first one was about scale, but it was about, you know, about time commitment and visibility of the chair, the chief exec, the managing director. I don't know whether Joe or Matthew or someone has a comment to that particular question, please.
Yeah, very, very happy to respond to that point. And absolutely, it's an important feature for our staff as well, Joe, in relation to that visibility, because we know the importance of staff seeing the leadership of the organisation, something we've embedded. I've certainly spoken to Glenn Burley about this particular topic, and I think his intention, subject to obviously, you know, approvals and so on, is to have a follow-up conversation with me about how that model would best work, and making sure that the importance of visibility of both the new chair and chief exec is taken very seriously, particularly during the transition period. But obviously the balance there, I think, is also going into the future, making sure that the board and the leadership of the organisation feel autonomous and being able to lead the organisation in the way in which the organisational fit makes most sense. So I think it's a known issue. It's an issue that's being taken seriously, and I think it will be a topic of conversation going forward during that transition period, subject to approvals by the various organisations. Hopefully that answers the question.
Thank you, Matthew. I'll take a couple of hands, and then we'll just go back and check we've covered off the other areas that Healthwatch have raised. Karen.
Thank you, Anita. It's a comment rather than a question. And I guess it's just to say that in terms of the very helpful conversation that we've been having this morning, that if we were appointing a chief executive and a chair directly and through other means, many of the issues and the things that we've talked about would still be there, particularly that level of uncertainty around fit, around new people, around the impact of any change. Having said that, this is different, and I think it's important to acknowledge that whilst there are similarities, it is different. And I guess I just wanted to commend and comment on the significant level of consideration that has been given to this change. And my perception and my experience of this all the way along is that the patient and patient services has been at the centre of that all the way through. And I just wanted to make that comment because I think that's been a very important driver.
Thank you, Karen, for saying that. And I wonder if I could just piggyback off that comment, because one of the things that Jo mentioned in her letter as a question was about where we were talking about conditions for success. Did we have any thoughts about specific pathways, specific types of services that had formed part of these conversations? I don't know whether who would like to respond to that?
I can start if that helps, Anita. So I think we were looking at this in the round, but clearly we're interested in looking at our priority areas, and we know that some of the delivery of flow both in and out of hospital is one of those challenges. So I think sort of understanding better how Swift have operated and the other trusts operate in terms of the vertical integration model was something of real interest, and how we can better manage some of those community to acute bed usage. The other was the frailty model that I think we've already talked about in terms of, there's an exemplar in Swift, and we know it's an area that we want to be able to improve from our perspective. But I noticed that Christine has put her hand up, so I shall defer to her.
Thank you, Jo. Christine.
Yeah, it was about the integration piece, actually. So within the rest of the group, there is much better integration between acute, community and primary care than within our own place-based system. And I think we can learn a lot from that about making pathways of care seamless for the patients as they move between different care settings. And that doesn't necessarily mean we have to become an integrated organisation, but certainly in the conversations we had with Glenn about those models, he felt that we would be able to learn better how to integrate with, how to work more closely and more seamlessly with our own community provision without necessarily being fully integrated with them. So I think there's definitely something to learn there, and that is of course the main reason why South Warwickshire is an outstanding trust, because of that, because of the integration with the community services.
Thank you, Christine, and that's helpful. Right, Simon.
Just to come back to Joe's question and Healthwatch's question about visibility of the chair, and this is something I've challenged Russell Hardy on, and the other two deputy chairs I've spoken to so far at Swift and at Wye Valley. How they work is they operate what's known as an enhanced deputy chair role. So while Russell will be seen around the hospitals and our services, and I've tested that out as well, people have told me he pops up more often than you think. Nevertheless, there will be an enhanced role for probably myself as deputy chair in line with what happens in the other trusts. So I think between the two of us, you might actually get more visibility of at that sort of chair, deputy chair level. I think maybe also just given the issue of our size, and if we do join the foundation group, they may have a look at how that operates and other parts of how their governance operates, given that we are going to be considerably increasing the size of what the foundation group is. But I know our other non-execs are very visible around the trust as well, do a lot of visits as well as the executives do. But on that very specific point of visibility of the chair, I think the chair and enhanced deputy chair model should cover that off, Joe.
Thank you. I don't see any other hands. So if there are no, Simon, were you putting your hand up again?
Sorry, it just popped back up accidentally. Do beg your pardon.
Okay, that's fine. Okay. Right. Christine has put her hand up.
Yeah. Can I just say one thing else about the visibility team piece? Because if you look back to the Good Governance Institute report, it talks about there are many positive comments about the executive team, including their openness, how well they listen. Staff feedback from the executive team was positive, portraying them as approachable and visible. Nothing about that is going to change under this arrangement because the executive team will be the same and carrying out their roles in the same way.
Thank you. Right. Oh, Richard.
I'm just going to add to what Christine said, Anita, and increase as we not only do our routine visits, but building Gemba visits as part of the rollout of the fraud improvement system.
Yeah, indeed. Okay, then. I think that is that's brought to the end of our questions. Joe Ringshall from Healthwatch, I wondered if I hope we've addressed the questions you raised in advance, but I wondered if you had any final questions or comments for us.
No, thank you for the wide-ranging discussions and for covering off our questions. We absolutely recognise the potential benefits of full membership. And absolutely recognise that this is actually a question of governance for you. So we were just hoping and I think probably received assurance from you, the board, that you are absolutely covered off on the capacity and commitment and how this is going to go forward. So thank you for that.
Thank you, Joe. So if there are no further comments or questions on, Joe.
Sorry, Chair, I might be coming. I was just going to. Can I just go through the next steps, if that's all right, before we move to the recommendation, because they're just in the paper. Well, right. just following. Sorry, just following the discussion. You'll see in the paper it just describes under item 10 the next steps, because clearly this is something that's affecting not only our trust but the other member trusts. So assuming approval this morning, the application for formal membership will be taken to the other trust group members, and the boards meet in the weeks commencing 7th of July. And therefore the trust first formal foundation group meeting would be on the 2nd of August. And that's all subject to the above, then the requisite appointment processes would be undertaken. And that's both for the appointment of the chair, which is an NHSE responsibility, and the chief executive, which would be handled under our statutory HR processes. So I just thought it was worth highlighting that in the paper. Thank you.
Thank you. Yes, indeed. That it's in section 10 of the paper. But yes, thank you for drawing that to people's attentions. Okay, so if there are no further questions, comments, I think we can now move to formally considering this paper. I think the comments of our board colleagues are have given us a strong indication that we are, as a unitary board, in favour of this this proposal. So can I please ask for approval to, as Joe says, to make a formal application for full membership of the Foundation Group Provider Collaborative, and to then invite the Chair and Chief Executive of the Foundation Group to take up the roles with effect from the 1st of August of this year. Can I ask for the board's approval of that motion? Thank you very much. I'm seeing lots of nods and thumbs up. Thank you very much to everyone that's been involved in this. Yeah, a good result. Thank you. We are unfortunately, we've overrun quite badly, but I felt it was important that we devoted enough time to this discussion, and so I've done it quite deliberately. So if we're okay, let's move on then to back to our agenda, the integrated performance report. Thank you. That's Vicky, I believe.
Thanks very much, Chair. So just in the interest of time, I'll just introduce that briefly and then pass over to Executive Director colleagues. So the Integrated Performance Report for month 1, it has an overall assurance level of 4. As you would expect with month 1, it does talk to the operational performance factors that we've experienced during April, which included the industrial action and the impact of that on the elective programme. The quality and safety metrics are referenced within the report, though the national trajectories were only received after this report was published. There's conversation in there about people and culture and also the finance piece. And I'll pass to Matt in the first instance, if I may, Chair, to talk about operational performance.
Okay, so I'll take the operational performance element as read. Given time, I'll try and just pull out the key elements of it. So if we go to patient flow in the first instance, so 12-hour breaches remained elevated. So 317 versus approximately 350 in March. In terms of length of stay, we've seen an increase in the average length of stay in terms of non-elective patients from 7.6 to 7.6 versus 7 days in March. Positive for you, so positive in terms and I do like to talk about positives. So in terms of the over the hour ambulance handover delays, in April we predicted it to be a significant improvement from the position of 1005 in March, and we had 696 over the hour delay. So actually we did see that positive improvement, which is excellent. I think that for me, I can spout out lots of detail in terms of figures, but it's about what are we doing about it. So in terms of flow, obviously there's been an ICB commissioned report, and it's about effectively and efficiently and rapidly looking at the issues that are highlighted within that report and acting on them. So we need to do that. We have the Home First work stream, so it's about delivering that as well. I think key areas to look at are direct access pathways, so bypassing ED, and actually myself and Christine were at the ED team meeting, and Christine eloquently talked about some of the direct pathways that we're going to be soon putting in place, so that was excellent. If I come on to elective recovery, our 2-week performance decreased to 84%, and that was largely around skin capacity. I have to say that we did have a meeting with the Wye Valley Trust yesterday evening around dermatology, so we're looking at where we can work in partnership, and actually that links back to the previous conversation that we've just had, so that's excellent. Quite a few of the Neds have asked me about urology, how have some of our regulators, so I just wanted to pick up on urology because we remain in tier 1 for it. So there was a regional meeting last week. We've had 3 offers of mutual aid. So they come from University Hospital of Coventry and Warwick, Cheltenham and Gloucester, and also Northampton. So we're looking at that. I've had a discussion with our divisional director actually at about 7:30 this morning, and we're looking at in terms of that capacity coming online within the next 2 to 3 weeks. So I think that's a real positive. And what I want the board to recognise is that we do have issues, but actually we're doing something proactive regarding it. Also, we're formulating a urology area network with the Wye Valley Trust, but we need to put in place an MDT with the University Hospital of Coventry and Warwickshire. That needs to be in place first, but that is happening. In terms of faster diagnosis, we're still performing well at 67%. It was 70% in March. As I've already said, urology is a key area of focus, but we're looking at that. If I move on to our continue to maintain 0 104-week breaches at the end of month. We do manage 104-week breaches within month. In terms of the 78-week target, we remain in NHSE Tier 1 for support. However, again, and I want the trust to be aware of that, we have proactively put a plan in place and we have brought insourcing in, and we're looking to be at 0 in July rather than the Q4 that we're predicting. So organisationally, I think we've done really well in terms of that. Given time is of the essence, I'm going to move on to diagnostics. So we've achieved 97% of our submitted plan. Diagnostic waiting list and patients waiting over 6 weeks has increased by 7%, but we remain within 1% of achieving the NHS target of no more than 15% of patients waiting longer than 6 weeks. Chair, I'm going to leave it there. Any questions? Of course, I'll take them.
Thank you, Matt. Are there any questions for Matt on his report? Oh, Simon.
Thanks, Matt. Just wonder if you could go into a little bit more detail about the page 19 reference to patient flow and what we're doing at ICS, ICB level for that 30-minute trajectory. I know you touched on it, but if you could give a little bit more detail, that would be appreciated. What are we also doing with system to, and this is something we've discussed here before, prevent people coming from ED who don't actually need to be there, who should be somewhere else? I don't know if there's an update you can give on where we are with that. And I note the comments about dermatology and the work with Wye Valley. But is there anything else that we're doing, given the challenges that we've got with dermatology? And I think there may have been some approach to the ICB to discuss that as well.
Okay, so I'll take those in order. So in terms of the system and the system response to the target, we're still in discussions about that. I think for me, it's about what we can do internally. If we look at sort of the recent report commissioned by the ICB, sorry, in terms of the flow, it was around the relationship between ED and some of our wards. And I think that's something that we need to sort of look at quickly, and that needs to be dealt with. And of course, that's working with the CMO team as well in terms of moving that forward. I don't know whether that answers your question, but I think we've got to do what's within our gift, and then we have conversations with the system as well. So I think we're actively doing that. And as I say, we're in a meeting with the ED team, or I think it was yesterday or the day before, just in terms of moving that forward. Can I just ask what the? Sorry, go on. Of course you can, Christine. Yeah.
Chip in there, Matt, and add a couple of other system-wide things that are important to reference. So we have discussed here, haven't we, whether some of our issues with patient flow are related to the fact we do get patients who attend our emergency department that might be equally well served by having their care elsewhere. There is a piece of work at system level looking at alternatives to ED. So we're mapping the directory of services that are available outside of the organisation to work out what is available, what its hours of operation are, how you can access it, and what groups of patients go there. We've also had support from the system in principle with a single point of access, which is a similar model to operates in Sandwell and West Birmingham, where for GP referrals, you set up a bureau, which is a bit like NHS 111, but you take patients through an algorithm and direct them, for example, to hot clinics or to ambulatory facilities or to facilities outside of the hospital to try and minimise flow of ambulatory patients to the emergency department. And that proposal is being worked up at the moment. In addition, the GP model for the emergency department is currently under review by the system, with some recognition that what we've got is not achieving as much as we would like to. So that is under review. And the final thing that the system are helping us particularly with is towards the discharge end of the patient pathway, where we've had the review of the work of the onward care team and how we refer patients and manage patients who are being discharged on complex pathways. So there's quite a lot of activity within the system to try and support us with patient flow, whilst recognising that we've got a lot to do ourselves, and I'll be talking a bit more about that at the private session later.
Thank you for that, Christine. And I suppose for me, it's all about pace, isn't it? So in terms of looking at things is great, and in terms of pulling plans together, but it's actually about how quickly we can get them in place in order that they affect change, would be my only comment in terms of that. I think that was one more question there that I haven't picked up on.
It was just on the dermatology side of things. I know you comment about Wye Valley, but if there's anything else you can say as well.
So Wye Valley, but also we're looking at sort of potentially a deep dive as well, just in terms of how we can make our service more robust. What I would say in terms of sort of moving to that foundation model, then that may well make it, when we've talked about sort of attracting people, etc., that may well make it more attractive. But there's internal discussions going on in terms of recruitment and how we can make that service more attractive to clinicians, because actually, as you say, that Wye Valley model is in response to an immediate issue. We need to make sure that the service is resilient in the mid to long term as well, Simon. Thank you.
Thanks, Matt. Richard.
Thanks, Anita, and also thanks, Matt and Christine, for answering some of the questions I had as well. I think it's really good to hear that there's a set of actions being agreed with the system, both to manage the front door better and, let's say, discharging, because we, in our plan for 23-24, have made a whole set of assumptions around this. So it's really important to quantify this and to act on it, and it's good to hear that we see some action there. I still have a concern, Matt. I know that we've had some industrial action and that also COVID has influenced our performance in months. But we also set a set of assumptions around what our activity levels should be in order for us to deliver on our annual plan. And on those activity levels, we've really not met quite a few of them in the first month of the year. So what are we doing to catch up? Do you feel we can still catch up? And do we have trajectories in place for the coming months?
So I feel that we have the potential to catch up, just in terms of how we're actually dealing with that. So obviously, I'm relatively new, but in terms of the industrial action, we're looking at the activity that has been, unless you want to come in, Matthew, do you want to come in first, or can I finish? Is that okay? So just in terms of the activity that has been lost, we've got an elective recovery. So if we take elective recovery, for example, an elective activity, we've got an elective recovery task force, and actually the amount of activity that has been lost will be, that issue is put through to the task group in terms of coming up with a solution and trajectories in terms of recovering that performance. So that's something that we haven't done previously, but in terms of having a clear process in place to try and recover lost activity, that's what we'll be doing, Richard, and there will be trajectories against that. And I think we need to do it in a methodical manner like that as well. Does that answer your question?
Yes, thanks, Matt.
Thank you.
Thank you. Matthew.
Yeah, just thanks, Chair. Just to add to those points, I think there's certainly the as Matt said, the real grip and focus on elective delivery, but there is, of course, and Richard, I know you'll be thinking this in your head anyway, there is the read across to the financial plan as well, because clearly delivery of activity impacts on the finances, and we've now commenced our focus on the financial recovery for this year. Recovery because we know we've got a significant challenge, and there's a lot to do to deliver on our financial plan this year. So we're looking now on a weekly basis. We've always had a weekly activity report, but we're developing that further into being able to scrutinise at service line level delivery of outpatient appointments, both new and follow-up, and also day case and elective surgery, so that we can really ask the questions of what's going on. And what support do the services need, and really get into this in a greater level of detail, as Matt said, from both an activity and performance, 78-week, 62-week performance cancer delivery, but also the read across into finance. And our group, which of a mixture of all the talents, as Neil describes it, are working really well together to try to make sure that each week I can scrutinise through our transformation delivery board that delivery of activity, so that we can understand where we are, what the risks are. If industrial action continues, I'll take the opportunity once again to encourage the health unions and the government to sort this out, because this is highly disruptive for patients and highly disruptive for our staff, and is impacting on every patient that is delayed or cancelled or postponed. Has an impact on another patient who could have gone into the slot that patient is being relocated into. So we really need some help from government here to get this sorted out, and from the health unions to get this resolved. But we will continue in the way I've described to focus on this on a very regular basis by our teams, but certainly weekly by me during the remaining time I'm here.
Right. Thank you, Matthew. I am starting to become quite concerned about time. So what I'm going to suggest is, for the rest of this, can we we'll go by section, but only on exception basis, I think, if there's something specifically you wish to draw to our attention. But I think, we've got quite a lot of the agenda still to go, and we've also got the trustees afterwards. So I think we need to pick up the pace a little bit. Matt, thank you for that. I think you've covered diagnostics, quality and safety. Is there anything to comment on that's not in the paper?
I don't think so, Chair. There's been no significant shift in our quality metrics in this reporting period, but I'm very happy to take questions.
Thank you, Christine. Any questions on quality and safety? I don't see any. Thank you. People and culture. Tina, is there anything you want to draw to our attention that's not that may not be clear in the paper?
Something, please. That was
Tina, we can't hear you. Could you speak up a little bit?
Lean in a bit more. Is that better?
That's better. Thank you.
So sorry for my close face. Just to say that we did have a detailed discussion at the People and Culture Committee this week, and the need to do a deep dive on our sickness absence, because we're now sort of seeing the COVID being mainstream, but we're seeing higher absence rates than the post-COVID pandemic. So we really need to get underneath that, make sure that we've got the right offer and managing and supporting colleagues appropriately. So that's the main focus for the next meeting. Thank you.
Thank you, Tina. Any questions or comments for Tina on people and culture? No? Okay, financials. Neil, we've talked a little bit about it already. Is there anything you particularly want to draw to our attention?
Yes, just very briefly, Chair. So there is no month one, so you're not seeing a complete picture here for month one, but just to highlight, we are off track on employee expenses, very much driven by strike action, and hopefully some good news in terms of the additional costs of covering vacancies, maybe over estimating what we'd anticipated in the month.
Efficiency, productivity and efficiency slightly off track at this stage. It will ramp up as we go, and as Matthew's already outlined, we need to be on this on a week-by-week basis, and that's what we've stepped up internally as our process to get visibility over certain assurance on that. Just very briefly, if I can, Chair, in the pack, you'll see that we are looking to do something slightly different around our costing and being able to compare on a month-by-month basis our weighted activity units at a more granular level, working with our divisional leadership teams to get a bit more of a sophisticated understanding of what's driving our costs on a regular basis. We will have a separate board session, Finance and Performance Committee session. Board is welcome to come along just to get into that in a bit more detail in the next month or so. But happy to take any questions, Chair.
Thank you, Neil. Any questions or comments for Neil on his report? I don't see any hands. Thank you very much, and thank you for your indulgence for us to sort of pick up a little bit of time there. Let's move to committee assurance reports. Again, I think, can we take them as read, and if the committee chairs could just highlight anything that they wish to draw to board's attention. Finance and performance, Richard.
Yes, I'll try to be quick, Anita, because I do feel that the report was a little bit over-summarised in this case, and I want to just pull attention to the fact that we intensively discussed the risks in the 23-24 plan and the need for mitigation, for potential mitigation on that. The need for detailed trajectories on activity, PEP, and risk assumptions, and the external dependencies, which you just discussed with the system. But there's a significant amount of things we have control over ourselves. And then the need for strengthened delivery focus, and Matthew talked a little bit about this with the Transformation Delivery Board, and the sense of urgency, because we're into the year significantly already and we're behind on some of our metrics. So just wanted to emphasize the importance of it and our focus in the coming months.
Thank you, Richard. All points well made, and I think we'll be talking a little bit about the risks in 23-24 later on today. So thank you for that. Quality Governance Committee, Julie, anything you want to draw to our attention?
No, I think take it as read. Thank you.
Thank you, Julie. Again, if anyone does have any questions or comments on anything, please do raise your hand. I think that's all we have there. So thank you for those. Let's move on then to safe staffing. I think we've got nursing first and then midwifery. Sue, in the interest of time, can we take your paper as read? And if you could just draw to our attention anything you particularly want us to be aware of. Thank you.
Thank you, Chair. So just draw to your attention that paediatrics, neonatals and the adult areas were all deemed safely staffed during April. Also as well, safe staffing was maintained during the RCN strikes, which took place on the 30th of April and the 1st of May. And there were no staffing related incidents reported on either of those days. We are undertaking a further acuity and dependency review, and that's scheduled to start on the 26th of June. Just to highlight that our vacancies continue to decrease slightly for our RNs, remain pretty static for our HCAs. Domestic recruitment is continuing successfully, and we remain on track with our trajectory for our international recruitment pipeline for 23-24. And I think those are the main things to highlight, Chair. Thank you.
Thank you, Sue. We note assurance level of 6 on that report. Thank you. Justine, midwifery, again, could I just ask you to just draw sort of the most important things to our attention, please?
Yes, of course, Chair. So, as you say, April's report, level of 6 of assurance. We're at trust target now for both our vacancies, sickness and turnover, which I think is important to highlight. We didn't use continuity or community as part of our escalation, and we met our acuity on delivery suite by internal redeployment of staff. The incidents reported with no harm. I think what you'll see in the report is in our unified data is an issue now starting to become evident around our support staff. whilst we have recruited for, that's just to assure you that that will improve. I think the report requires a little bit more focus on that particular staff group for next month, and I've requested that separate data from HR, which you'll see next month. So I think that's probably as much as I need to say, but a much improved position.
Thank you very much, Justine. And as you say, assurance level of 6 that we note. Matthew.
Yeah, thanks, Chair, and thanks, Justine, for your report. And good to see that those numbers are going in the right direction. I suspect you'll be pleased to see the back of me continuing to press on those. But I guess the question that obviously this starts to then lead into is the question of restarting or re-engaging with the conversation around continuity of carer. Given that our board position on that is that we believe that it's still the right model despite some lack of direction that we've experienced over the last year or so from national leaders. Is there a comment that you can give to board at this stage, or is that a bit unfair to ask you to give a view on that at this point? Feel free to say no.
I think it's quite challenging because we should be in a positive position by the end of this year, and at that point really have all of our milestones in place. I think we need to consider as a board the risk of any further rollouts and look to our neighbours to see what they're managing to achieve, because as you know, we are currently best in region, and I think some of our colleagues possibly need to look at what's being delivered more locally, because I think there is a risk, we know, of attrition should we progress with this when some of our other local services are not delivering this model, because it is hugely popular with many, but it's hugely unpopular with many also. So I think we need to take a very measured approach on our next steps.
Thank you,
Justine. Yeah, if I can just come back on that, yeah. Chair. So I wonder again, just sort of teeing things up for the future. I wonder if we can task Justine and Sarah to work together with board colleagues and with Sue as maternity safety champion too, to bring back to board at some point in the future, if you like, a roadmap for how we take this forward, given the journey that we've been on, and you know, I'm looking forward to one of the things I'll be doing in my last month or two is spending some time with one of the continuity of carer team that I've developed a relationship with, and it's important that they feel supported as well as the board considers what the right approach is. So if I could make that suggestion for us later in the year, perhaps. Thank you.
Thank you, Matthew. A good suggestion, and I hope the team takes it forward. Thank you. Thank you, everyone, for those reports. If we can quickly go through the next few, because obviously I still have my chair's report to come at the end as well, so we need to squeeze that in too. So, board assurance framework, Rebecca, anything just to highlight to us, please?
Yes, thank you, Chair. Assurance level is 5. The paper's been through the various committees within the board. The board is asked to approve the closure of the health and wellbeing risk as a result of the award-winning service that Tina has already described today. What People and Culture Committee will be doing is a specific focus on our staff sickness, as she described earlier, and may well result in a new risk being opened in its stead. The rest of the assurance framework is as presented. Thank you, Chair.
Thank you, Rebecca. As she said, it is for approval, level 5. Oh, Christine.
Yeah, just to note really that we will probably need to revisit the industrial action risk on the BAF as well. It is one that fluctuates according to how well we can mitigate it, but I do think it's not quite right at the moment.
Yeah, and it's exactly that. This is what demonstrates this document is a very live document. And as we've seen this risk escalate and de-escalate across that industrial action period, you know, absolutely we'll be looking to make those changes at the appropriate point.
Yeah, thank you. Absolutely. Right. Approval level 5. Can I have your agreement, please? Thank you very much. Audit and assurance report. Colin, again, in the interest of time, is there anything you particularly want to draw to our attention? Thank you.
Just one thing, Chair. The item 4, draft head of internal audit opinion. We received a moderate head of assurance opinion, which was not unexpected, but nevertheless disappointing. So I think we need to just think about that. It will have a track through implication for our annual governance statement. We perhaps need to learn any lessons that need to be learned for the future.
Thank you, Colin. Any questions or comments for Colin? I don't see any hands. Thank you. TME report, Matthew.
Happy to take any questions, Chair. Nothing particularly to know. Colleagues will be familiar with many of the topics as they've come through to all committees. Thank you.
Brilliant. Thank you. Any questions for Matthew on TME? No, I don't see any. Thank you then. Terms of reference, Rebecca?
Yes, thank you, Chair. In terms of reference attached, been through the committees, there's no changes of substance and have been through minor housekeeping updates. Thank you.
Thank you very much. This is an item for approval. It's the terms of reference for F&P and QGC. I don't see any hands raised. Can I have your agreement to approve those revised terms of reference? Thank you very much. Right then, so any other business there? We didn't have any. So I wonder if I could now just take a few minutes to give my chair's report now at the end. As I'm sure everyone will be aware, this is Matthew's last board meeting with us. I come not to praise Caesar, but to bury him, I suppose, is a bit of it. But I would like to just remind ourselves of the journey that we've been on in the 4.5 years that Matthew has been with us. He joined us in January 2019. It is almost exactly 4.5 years until he leaves us at the end of July. In September that year was when our CQC ratings went up to requires improvement from inadequate. Later that year, we approved our first clinical services strategy. In June 2020, we launched the first of our staff networks, the BAME one, and obviously we then went on and did LGBTQ and disability and multi-faith. In September 2020, we came out of quality special measures after it was nearly 5 years, and I think we still hold the record for that, unfortunately, but we came out in September that year. In April 2021, we started work on the urgent care village. Obviously, that project has not yet come to fruition, but hopefully will be very soon. In February 2022, our new breast imaging unit at the Alex. May 22, the new endoscopy suite at Kiddie. June 22, we were recognised as Veteran Aware. July 22, the CoLab at Kidderminster. Also that year, we were recognised nationally as an employer with heart when we became one of the first NHS trusts to offer paid leave for staff undergoing fertility treatment or experiencing baby loss or preterm birth. In August 22, our new CT scanner and ultrasound facilities at Kiddie. September 22, our robot was finally delivered to the Alex, and we started our journey onto robotic surgery. November 22, our first live staff recognition awards are for several years, which I know Matthew and I had a ball doing last November, and it was definitely one of the highlights of my last year. And then in January, just in the last 6 months, we approved the last bits of the acute services review, which will lead to endoscopy services at the Alex and at Worcester, theatres, maternity triage and assessment, remodelling of the Riverbank Children's Unit, combined paediatric assessment unit and children's clinic. And then, of course, in February this year, our EPR phase 1 went live really successfully. And then finally, of course, or say not finally, in April, we had that CQC published their report after their unannounced visit to our emergency departments. We went from inadequate 2 requires improvement, and for the first time in many years, there were no inadequate ratings at all for any services in the trust. For anyone, that is a remarkable list of achievements. Matthew has worked tirelessly for us in those years, and that ignores, by the way, that the things he did over and above that, doing a night shift with an ambulance crew, putting on a porter's uniform and working as a porter just to see what it was like on the ground, to the people that see everything and who are often not recognised as they should be. Matthew has had a tremendous impact on our trust. He has led this ship on this journey of improvement, and on behalf of the board, I'd like to thank you, Matthew, for all your contribution, for everything you've done. We wish you very well in your new role, but I think that's a legacy that you can be really proud of. Thank you.
Thanks, Anita. Thank you, and I'm sure there'll be other opportunities to thank everybody, but thank everybody on the board for the great support you've given me in, as you say, in the last 4.5 years as chief exec of the trust. Obviously, massive thanks to my team. You're a pleasure to lead, an inspiration, and troublesome at times, but generally good value. Vicky, Lewis, and also particular thanks to Dame Julie, Colin and Richard, as well as you, Anita, obviously involved in my appointment, and the words of Dame Julie Moore 18 months or so after I'd started, saying you've turned out better than I thought you would, is praise that I will take with me through the rest of my career, and I thank you for that. So massive thanks. In a month or two, I'm going to have a new kitchen, a new wife, a new job, and I'll look back on my time at Worcestershire Acute very, very fondly, and with a little bit of sadness that we haven't fixed these wicked issues yet, but I'm hoping that we've set the foundations now for a successful next chapter of the organisation. I'll be looking from down south fondly back up to the Midlands to see how everybody gets on, and look forward to talking to everybody and sharing perhaps a cold drink or something between now and when I finish. And massive thanks to all of you, and Joe to Healthwatch as well for your support. But there's more to do, so better never stops, colleagues. Thank you very much, Anita.
Thank you. And obviously Matthew isn't leaving imminently. He doesn't leave till the end of July, but because he'll be on his honeymoon for our next board, I thought we'd do this now. Right. Thank you. We are moving, if we may, straight into our trustees meeting. That's a meeting of the board as trustees of the corporate trustees of the charity. You should have the papers in your pack. Apologies for absence will be as for our public board. Declarations of interest are on the website. Minutes of the board meeting are in the pack. Can I have your agreement that they're a true record of that meeting? Thank you very much. Moving then to this report. Is that Simon that does this report?
Yes, it will be, Anita. I mean, it is a brief report. We're making good progress with the Charitable Funds Committee. A lot of exciting initiatives underway. The Staff Health and Wellbeing Day was a great success, and as Michelle will bear testament to, when we did a visit to neonatal earlier this week, one of the people who attended that Wellbeing Day is now taking up the lead for her whole section on their health and wellbeing and initiatives for what they're going to do there. So it has had a real impact. But I'm happy to answer any questions on any other aspects of the report if colleagues have any.
Thank you, Simon. Any questions for Simon? Richard?
Not a question as such, Chair, but just to reflect on the very positive charity away half day that we had on the 18th of May. which was a really engaging session. Got colleagues around the table with an external facilitator to start really looking forward in terms of how we build on the success of the charity in the coming years in what we know will be a very challenging fundraising environment. But it was a really enjoyable session and some great ideas, great energy in the room, and I think it will put us in a very strong position to take the charity forward.
Great. That sounds wonderful. I was sorry to have missed it, but no, that's lovely. All right. If there are no other questions or comments for that report, it's for assurance. We don't have any other business. So I will bring this meeting to a close. We've actually ended up ahead of schedule after all that. Isn't that fantastic? So well done. You get a little bit more of a lunch break. For board members, we restart in private session at 1:15. For everyone else who may have joined us, thank you very much and hope to see you soon. Thanks a lot. Bye-bye.
Thanks, Anita. Thanks, everybody.